Good afternoon. This is the second session, or the English session for the EDIC exam orientation. So some of our colleagues just requested an English version of that orientation. So I guess I'll introduce myself again. My name is Mohamed. I'm an intensivist. I started my career in 2010 in Cairo University Critical Care Department, and thereafter I finished my master. I had my master's degree in 2015, and then my MD exam. I finished the written part of my MD exam, and there remains the oral part. During this period, I got an opportunity for a fellow program. So I had this fellowship in Manchester Royal Infirmary, or in the Manchester Foundation Trust. I spent 1.5 years in the general ICU, and then shifted to a cardiothoracic ICU rotation. It was an ECMO and heart-lung transplant center. Through this period, I got my EDIC exam with the 2 parts done. So I guess I may give you some helpful advice about that, and about the course we are starting, or we are just orienting you about with this course center. So just a quick review. I've prepared some stuff in this paper. First thing is, what's the EDIC? It's an European Diploma of Intensive Care Medicine. They call it in Europe the ICM. You may call it critical care or ICU. The aim of the exam is to give you a standard, or to make sure that you are at the edge of a certain standard of knowledge and skills practice as a registrar in the European Union or outside even Europe. It's mainly intended for you to examine you on this level, a registrar entry level in the European Union. I think in UK now, I'm sure it's replaced by the FICM, the Faculty of Intensive Care exam. You must, if you are ICM trainee, a linear trainee, I mean, you need to pass the 2 parts of the FICM exam to pass your training program, whichever way you've entered this training program. So again, in our countries or outside the European Union, India, Pakistan, even in our in Egypt, or I'm from Egypt, by the way, sorry. In the Arab world, you may need to enter this exam for some certain reasons that we will say just later on. It's 2 parts, part 1 and part 2. Part 1 is the theoretical part of the exam. It's mainly MCQ. It's not theoretical like as in ESSE. There are 2 venues or 2 times that this exam is carried on. Through in April and in October. The previous April it was cancelled for the pandemic reasons, and next October you can still book the exam in Dubai, Kolkata, and London. I think till the 15th of July. The exam, the part 1 exam, it's 100 MCQ type A question, and more or less 50 questions, like 50% between type A and type K. Type A is a single best answer question. It gives you like 5 choices, and you choose from one of them. Either you get it or lose it. So if you just choose the right answer, you're okay. If you didn't choose the right answer, the mark is lost. Type K questions, 4 choices. It's not a single best answer. If you choose the 4 answers in the right way, in a correct way, then you will get the full mark. If you choose just 3 answers from the 4, then you will get half of the mark. If you made like more than 2 mistakes, you don't get the mark of the question. So type A and type K questions. The EDIC part 2, it's again 2 times a year. In May it was cancelled again for the pandemic, and in November you can still apply for the exam till the 15th of August if you've done already the first part. It's in Copenhagen, Dublin, Porto, Prague, and Vienna. It's an Osce exam, the objectively structured clinical exam, and there are 9 examiners that will examine you. The exam is divided into 2 parts: 3 clinical case scenarios and 3 computer-based scenarios. So the clinical-based scenarios will give you time before preparing for 2 case scenarios. They're different in like the size of the case itself. So you get like long case and more or less halfway or a medium-sized case and a small straightforward case. And then you just read the 3 cases and divide your time wisely between the 3 cases, and you expect the questions that you will be asked from the examiner. And then after you finish reading the cases, you enter the exam hall, and then you start to be asked about the first case, second case, and third case. Every station there are 2 doctors or 2 consultants, examiners, that will ask you. One is asking you and the other is just recording on an iPad or something like that. And then it goes like that. For example, my first case, it was infective endocarditis. It was discovered later on, and then encephalitis and lumbar puncture, and then some sort like that, some stuff like that. It started, again with convulsions. It started with convulsions, and then it wasn't a drug overdose, and then it turned into a line infection and infective endocarditis, something like that, as far as I remember. And then the patient went onto ECMO, was connected to the ECMO, and then there was some sort of end-of-life care. It goes like that. It's not just like only a drug overdose or some cardiac patient, and this is the case takes you from neurology to antibiotics, and then hemodynamics, and then advanced life support and mechanical support devices, and the exam goes on like that. So the second case, I'm just speaking about my own experience in the exam. The second case, it was like Hematemesis Case, and then it was like OV's esophageal varices and how to deal with that, and liver cell failure. It took you through the Singstaken Blackmore tube, and ending up with surgery maybe, or whatever you want to do as per scenario, if that's feasible. Maybe some sort of if it was not an OV, or it was like an ulcer, so you may need some intervention radiology to do some sort of embolization, and so on. The exams run like that. The exam runs like that. The restrictive strategies for blood transfusion and blah blah blah. So this is the way they examine you in the EDIC Part 2. Then they take you to the computer-based scenarios, where you find some. There's an examiner for each one of the 3 stations. They speak maybe, and you may see an echo, you may see an ECG, you may see some mechanical ventilator curves, you may see some biochemistry plots, and then you start to put some differential diagnoses and explain that for the examiner. high anion gap, metabolic acidosis, normal anion gap, metabolic acidosis, and so on. So that's a brief about my experience in the exam and about what will you expect to see in the exam. Again, let's go to some details. You maximally have 3 attempts in part 2, which I think it's a bit difficult for you to just go for the exam 3 times. I think it's part 2 in comparison to part 1. It's a bit easier, at least for me. Next point would be the fees of the exam itself. The fees of the exam, I totally recommend for you just to get a membership for the European Society of Intensive Care Medicine. I think it's, if you're in a training program, you will pay, I think, 120 euros, because this will help you. Maybe we will send you some of the privileges of the European Society staff that they will help you. They've got a journal, they've got some webinars, they've got like lots of things that they can help you with. But again, the fees, I think if you're, I'm sure it's if you're a member, part 1 or the edict part 1 would be 360 euros, excluding VATs. If you're not a member, it's 510. This is in a European center. If that's outside Europe, it would be 460 euros for the members, and for non-members it's 610. Part 2, it's 480 for non-members, and for members it's 680. I was lucky because I took the 2 exams, part 1 and part 2, in 1 year, so I made like full privilege of or full use of the membership. Again, they offer the packed modules, which are the explanation, the theoretical part of the edict. They've got marvelous stuff regarding the hemodynamics. I'm not advertising anyhow the membership stuff, and so. But again, I think it's worth it. If I'm advising someone, I was advised that it's important to get that, and to be honest, it was worthy. Again, for whom is the edict? I think edict is for people that needs European standardization of their practice. It makes you eligible as a postgraduate qualification for the GMC registration. Few bodies like the FICM and the Australian one have got a recognized kind of certificate, like the European Society. So they make so it's worthy getting the even in your CV the edict certificate. It's appreciated in India, in the whole Europe, in some Gulf countries, and so. For the entry for part 1, you need to definitely finish your internship and spend at least 18 months in your ICM or ICU training, and it's highly recommended, because I don't think anyone that didn't pass like at least 1.5 or 2 years would see, for example, an ECMO, or would see the different types of interventions, and would rotate in different ICUs, the cardiothoracic, the neuro ICU, general ICU. So it's requested from the society, the European Society, that you spend at least 18 months, and then part 2, definitely you need to pass part 1. You can't do part 2 before part 1, and you need to spend 24 months in the ICU, in an ICU training, I mean, or ICM training. So this is a brief about the exam, and about myself. I think the next step would be about the course. So I guess it would be beneficial for everyone that didn't have the European or the UK or the Western kind of experience or practice, because it's a bit different, at least from the practice that it's done in my country. for some resource differences and some culture in the ICU itself. So the ICU in Egypt, for example, I'm speaking about my own country. It started as cardiologist, starting a CCU, and then clinical endpoints rather than physiological endpoints. When you compare that to UK, for example, a country that I spent 2 years in, it started as anesthetists running ICUs, and then other specialties started to run ICUs and to have training programs in the ICU before it became a separate specialty. So again, it's a bit different from country to another. So you need, for example, to do some practice and to have some backgrounds about the experience, about the practice in Western countries and in Europe specifically. Something different that we do, non-anesthetists do, for example, the rapid sequence intubation. I was not doing that way anyhow. But again, before I went to UK, it was like, okay, we give some propofol, and then the patient is sedated, and then put the endotracheal tube just one way. You have no other options, you have no other plans. And to be honest, this is not the appropriate practice, first thing. And second thing, you're tested about some stuff like that. So rapid sequence intubation, for example, you need to know plan A, B, C, and D. You need to prepare your drugs. You need to get the patient in the right position. You need to get the be at ease protocol in UK. And then you need to know the grading, the Cormac-Lehan grading of the endotracheal intubation, and then deal with different situations like the high ICP patients, the bronchial asthma patients, different types of scenarios, why you give opioids like fentanyl, why you give them muscle relaxants, what's the rapid sequence, and what's delayed sequence intubation, and the difference between that and that, and this in the DAS, or the Difficult Airway Society. So I'm speaking about this stuff. You'll need to learn about some of this stuff, and this is what we'll try to offer you in the course, not only specifically about the airway, but about other topics. In different ICU topics. So again, this is the first point, the Western experience, or the European practice that you need to have some sort of background about, and different cultures from where we all came from. Second thing is the exams. You need to know some key points. So I'll not be speaking about the whole ARDS stuff, but I'll be speaking about a stepwise approach for an ARDS patient, a protocol, and what's the evidence of proning a patient, when do you need to prone the patient, the studies about that. You need to know some brief stuff about them, and this is how it runs. If you had any experience about the MRCP or the OSME, you will know that it's not about medicine or about like surgery, if you had an MRCS or so, but it's about MRCP, it's about MRCS, it's about USMLE. You need to know how to take this exam and how to be prompt, and the pathways and the questions, what are the sources you will need to study, and how to revise. It's about the exam itself, how many MCQs you will need to answer and you need to take before the exam. So this is important, this is the second point. We'll have some targeted MCQs from some recommended sources and some assignments as well, to make sure that you prepare well for the next session in our course and for the exam definitely. And we'll do some MCQs through the session itself. Again, it's about exam-oriented approach. So I was asked about some papers, the TRIC and the TRIS studies for the conservative blood transfusion. I was asked more than a time about toxicology stuff. So in the part 2 exam, you need to categorize your stuff. So you'll not keep like studying the post-operative medicine, for example, and you're not asked you'll not be asked anything about that. Or like stress on the MI stuff and the CCU stuff, for example, and you get nothing from this in the exam. So you need to be targeted, and you need to be to know the exam format. There will be some ethics and the organization and logistic stuff, like the oxygen transportation stuff, the safe transfer of a patient, and etc. So we will need that to get like much more confidence while having the exam. We'll do some mocks, 1 or 2 mocks at least for part 1 and part 2. And finally, our estimate is like 3 to 4 month period, the course, and there will be 1 or 2 lectures a week, average of 3 hours. It will be like more or less like that. I think that's everything I wanted to say about my experience about the exam. I don't remember that I said about the GMC registration, because last year GMC just approved the EDIC exam as an entry for registration. So if you had an EDIC after 2015, you're eligible to have a GMC registration if you pass the language requirements, which I guess the OET exam or the IELTS right now. So that's everything. Through SCORE, I'd be more than welcome for any questions or any queries, and that's it. Thank you very much.